I'll typically ask a client to do is, I'll just ask them to sit up, can you sit up on the edge of the bed for me? And I just let them take over as far as how they determine that they're going to do that. Obviously, we want to intervene if something is happening that's unsafe, if they have precautions that they need to adhere to. I may remind them, you have hip precautions, I want to make sure you know your hip precautions. So, if the bed's flat, so going from supine to sitting on a flat surface is a lot more difficult, okay? So if they're in a hospital bed, their bed might be raised, okay? The head of the bed may be raised. So if you wanted to challenge a client in bed mobility and you wanted to really mimic their home environment, if they don't have a hospital bed, you want to make sure you work on bed mobility in a fully flat position if you can. If the client has really poor trunk stability and poor endurance and strength, you may decide that you're going to put the head of the bed up and elevate it a little bit, because that's going to help the client to be able to get into that sitting position at the edge of the bed a little bit more easily. Okay, so you understand how that's a downgrade. Okay, so if Jessica is my therapist and she's asking me to sit up on the edge of the bed, and here I am struggling, obviously, and I'm grabbing things and pulling things, I would expect that, as Jessica is a good occupational therapist, that she's going to adjust the activity to meet the ability of the client, right? So what that would mean would be maybe she's going to elevate the head of the bed, okay, just a little bit for me, okay? She may instruct me that, so for bed mobility, we want to use gravity. Gravity is our friend, okay? So typically what I'll ask the client to do is turn to their side, okay? Maybe they're going to use the bed rail, perhaps, if they have that ability to. Then they're going to get their legs off, okay? So just by doing that, it's going to help to torque their upper body, their torso, into a sitting position, okay? And they may use, if they have a dominant side or an ineffective side, they may use that side to push to get themselves to a sitting position, okay? Using the bed rail, if that's possible. Okay, so really, you want to make sure that you're not letting your client struggle with the task for too long. Okay, so when we go in to do evaluation, we have an idea of what our clients can do, maybe from previous notes, perhaps by the diagnoses that they have. But we want to kind of see what they bring to the table. What can they do? All right. On next Tuesday, we're going to talk about orthostatic hypotension, so that's something we want to consider when we're looking at supine to sit and sit to stands, okay, with transfer. So we'll talk about cardiopulmonary status. But as far as for the motion, so once you have the client sitting at the edge of the bed, you're going to give them time to adjust to the position before you would ask them to complete a transfer. My practice, when I look at assessing a transfer from bed to wheelchair or bed to chair, is to first have the client to just stand, okay? I'm not going to ask them, I don't ask them to get into the chair until I can just see what their balance is and their strength is getting from sitting to standing, because that's going to determine what type of transfer that you're going to do with the patient, perhaps, okay, and how much assistance you're going to have to give the patient. What we tell our clients, and this goes back to where arm placement goes, you push from the surface that you're sitting on, okay? So wherever you're sitting, that's where you're going to push from. So whether that be the bed, the chair, commode, the shower chair, so you're always going to push from that surface. Nose over toes, okay? Nose over toes, and then come to standing, and then grab the walker. However, we do have clients that then they go for the walker first, okay, and they want to pull up on the walker to stand, okay, so we want to make sure that we're instructing in proper technique. If a client, sometimes clients really want to hold on to the walker, and that's okay, one hand on the walker, one hand pushing is acceptable. Okay, same goes for sitting. One hand can be on the walker, one hand on the surface, or they can go both hands back, okay, but typically, if a client has really poor balance, they may want that stability to just hold on to the walker and to feel a little bit more comfortable in being able